Okay, thanks for waiting, folks. Now I think we have all of our four speakers hooked up, and we will try to address as many questions as possible. Before we go into the Q&A session, because we get so many questions about which strategy has led to such a good outcome in Korea, let me just start off by trying to summarize some of the factors that we feel may have helped us bend the curve. We feel that there's has been about three key factors that has helped us deal with the pandemic. The first thing is actually getting the buy-in from the people of Korea. So the Korean people have been very cooperative regarding this serious public health issue. And because of this, several policies we have been able to apply several policies in our country. First is aggressive social distancing, as Dr. Che mentioned, is very important in preventing the spread of the disease. And second, everybody is wearing masks, and using good hand hygiene is very important as well. And third aspect is contact tracing. So whenever somebody has been tested positive, the government has been able to release the data on where that patient has been, so that everybody is clear on which areas the patient has contacted. Second aspect is the testing and isolate strategy. So because we have done a lot of massive testing in Korea, we have been able to identify the patients at risk and the high-risk populations, and we actually know who to target in terms of trying to mitigate the spread of the disease. However, one issue with doing massive testing is the quality control. It is very difficult to get the highest quality so that there is no contamination in the laboratories. And also the fast turnaround time. As you saw from the presentation, we do 4 rounds of tests every day in our hospital 24/7. So to get that fast turnaround time is very important as well. And I think in Korea, because we had, I think, about 1,100 screening centers where people can get swabbed and get tested for the COVID-19, that was one area where we were able to identify the high-risk patients. Third issue is whenever there's a big outbreak, the majority of the patients, even though they are confirmed positive, are very mild patients. So they don't really have to be admitted to a hospital bed. And therefore, in Korea, what we implemented was this thing called the Living and Treatment Support Center. So that is a sort of a quasi-hospital center environment where patients who have very mild symptoms could be kept in isolation, and also patients who recover from the disease and no longer need to be put into the hospital beds can be sent to those centers and also be isolated until they are completely negative and are not able to spread the virus. And therefore, getting a match between the stratifying the patients that are at the highest risk for the most severe disease and actually having them have the ability to be admitted to the hospital beds with the highest resources was very important in minimizing the fatality rate in Korea. So let me start off by asking Dr. Jin-Kyun Park. We have several questions here. One question is, there are many healthcare professionals who are at risk or can get infected or are getting infected in several countries. Can you tell us about the in-hospital strategy for preventing the spread of the virus in hospital?
So we have a very good number to report. We have no in-hospital infection. So no physician at Seoul National University has been infected with the COVID-19, which is very, very good. And I think one answer to that question is that we have been doing very well social distancing, but also everybody is supposed to wear a mask. So every physician wears a mask and every patient wears a mask. So if you have two people wearing masks at the same time, you have a double protection basically. So you have double barrier protection, and therefore the rate of transmission is very, very low. And that's one of the, to my humble opinion, one of the reasons why we have no in-house infection so far.
So the wearing masks on both the patient and for the healthcare providers is very important, in your opinion.
And the other thing is, as I mentioned in my presentation, we have this alert system. If somebody at risk comes to our hospital, we know ahead that this person is at risk. He comes from the endemic coronavirus endemic area, so we get the alert, and we are kind of more extra careful in that situation as well. So those are simple measures that really help a lot.
Can you also talk about the testing for all of the patients being admitted to the hospital as well?
So first, the patient who are at risk, they had to go through this screening test, and they get tested for COVID-19. However, as we know, people can be asymptomatic when they come in, and they might infect every other patient on the ward on the same floor. So to avoid or to minimize that possibility, every patient who gets admitted gets tested 1 or 2 days prior to the admission. That's one of the measures we have been taking recently, and it seems to be very effective so far.
Also, Dr. Pyongyun Che, can you talk about what we do, our policy regarding the healthcare providers who have been in direct contact with the patients who are confirmed positive?
Yes, during the first period of the outbreak, we do some very strict strategy to control, to prevent health-associated infections. So at that moment, we remove from the healthcare workers who contact with the confirmed case is for during the incubation period for 14 days. Even though the patient wearing some medical mask, but the patient did not wear the mask, so we think at that point it's very in some dangerous context. So we remove from the healthcare workers for 14 days at that period. But we think, so at that point we apply the universal mask applied to whole healthcare workers and the whole patient. And after that, there is no significant exposure from the moment.
Yeah, so I think we can break that down into sort of the healthcare providers who are working in the isolation rooms, the negative pressure isolation rooms that are actually the COVID-19 positive patients. So these healthcare providers are using fully equipped personal protective equipment, N95 masks. And in those cases, those healthcare providers, unless they have some sort of symptoms, they're not tested in a routine basis, and they can go about doing just regular daily work. In the situations where they're not wearing PPE devices and wearing N95 masks, but are just wearing just regular masks or dental masks. If we feel that that healthcare worker has been exposed to a confirmed positive patient, in the earlier days, because some of the patients were not using the masks, we used to isolate the workers for 14 days just to make sure, and then we also tested them to make sure that they were negative. But with the recent aggressive social distancing and also the aggressive use of using masks for all patients who come into all around the country and also come into the hospital, since both sides, the workers and the patients, are all wearing masks, we don't consider that exposure. Okay. Let's move on to sort of the diagnostics and laboratory side of this virus. So one question that we often get is, if RT-PCR is not possible, what do you think about the value of the rapid testing using the antigen antibody? So Dr. Park.
Korean manufacturers sell POC-based antibody and antigen test kits. In Korea, only real-time PCR test is approved by the Korean FDA and covered by the National Health Insurance. Antibody test is only available for research purposes. I have never used the COVID-19 antibody test, but the antibody test will be positive later and longer than RT-PCR. However, it is difficult to give meaning when the results are positive. In areas with limited resources and high prevalences, it may be used limitedly for screening purposes. But for diagnostic purposes, it will be difficult to use due to false negatives and false positives. And immunochromatographic assay is less sensitive than ELISA, so you must think of the limitations.
So basically, the golden standard is RT-PCR, but which we are using in Korea. But if you understand the pros and cons of the other tests, that can be incorporated as well. Can you also talk about sort of what it takes to maintain the high quality in the laboratory? Because that, I think, is one of the essential parts of dealing with this virus.
Most important thing is always test positive controls and negative control in same RT-PCR run. So that can prevent, that can check the contamination, and other factor is wearing PPE and negative pressure rooms, so the medical technicians prevent themselves from the COVID-19.
So always having a positive control and a negative control is very important, and then also having the facilities, including an isolation room with a negative pressure, is very important when dealing with the specimen. Another question is there any difference in the diagnostic rate of using the nasal swab, the oropharyngeal swab, or using the sputum?
According to the guidelines, nasopharyngeal swab is the single most recommended sample. I didn't show the graph of comparing CT values of same day, same patient, different sample types, because the number was so small. In early stages, CT values of nasopharyngeal swab were lower than those of oropharyngeal swab, and CT values of sputum were lower than those of nasopharyngeal swabs. However, sputum is not present all the patients, so nasopharyngeal swab is the single most recommended sample.
Okay, it's the most sensitive sample. Okay.
It depends on the clinical situation of the patient, and if the patient had pneumonia, at that time the sputum is most sensitive compared to nasopharyngeal swab.
Okay, thank you. So I think we can now move on to more of the clinical side. So one question to our pediatrics specialist, Dr. Choi, is what is the evidence on the available treatment in children? So the person who asked the question wrote azithromycin, hydroxychloroquine, etc. So can you give us your opinion about what treatment are available?
So currently the treatment data, even for adults, we don't have enough data to recommend which treatment is good or not. But for children, as we all know that from the data from China and Korea, the data is suggests that the children has very mild disease, and also a lot of children have asymptomatic period. So which means that we don't have enough experience to treat the children who had COVID-19. So we don't have such a good science in the treatment of children. But in the data for treatment, I don't think we have a different data from adults. So you mentioned that the hydrochloroquine or azithromycin, there is data suggesting that might help the patient to have COVID-19, but the data is not sufficient because the data is from a very small number of patients. But recently, preprint data from the United States that looked at the use of the hydrochloroquine with or without azithromycin in the United States patient, the data suggests that actually these two drugs does not help in improving the death rate or improving the rate of ventilation. In other hands, it is unfortunate the use of hydrochloroquine alone, it actually increased the mortality rate. So we have to be very cautious in concluding this treatment strategy is good or not. Before we do that, we have to pursue the very well-designed clinical trial and then see the results from the study.
Yes. So so I think the take home is what's important is the supportive care and not because currently we don't have a treatment of choice for the virus, and it is premature to say without getting data from the randomized controlled trials. I think we can expand this question to our adult patients as well. So there's clinical trials of remdesivir that's ongoing. So can you talk about, in general, sort of the treatment, Dr. Pyung-Kyun Choi, about where we are currently with the treatment?
Yes. Actually, we are participating in the remdesivir trial, but it's a double-blind randomized control trial. So we could not know which one received the remdesivir or not. But the enrollment is finished, so it will maybe 2 or 3 weeks later we can figure out the final result of the randomized control trial for remdesivir. But one single arm study was published in New England Journal of Medicine, but that data suggests that the responding rate is almost 17%, and so they argued that their mortality rate is much lower than the result from the clinical data for lopinavir and ritonavir conducted in China. So they think they might be helpful for the patient, but I think it depends on the patient population and the quality of the best supportive care is also affect the mortality rate. So we cannot conclude that this treatment is effective or not from the single arm study.
So the important thing with the recent NEJM result with remdesivir was the fact that it was a single arm trial and did not have a control arm.
From the data, we cannot figure out how virus was changed in their patient because they did not present the biological data. So we cannot conclude anything from that data.
Yeah, and I think we have historical experience with Tamiflu as well, and we know that with these antiviral agents, the timing of administration is very important. Whether it is 24 hours within symptoms or 48 hours within 48 hours of the symptoms, and then also is it reducing mortality or is it just reducing the duration of the symptoms? Is it effective in the very severe cases versus does it just help reduce the symptom in the mild cases? So those are all questions that we don't have answers to currently.
Yes, that's right. So in my personal opinion, from the viral kinase data, the viral was highly replicated during the first period of the patient within 5 days from the symptom onset. So, but the patient developed pneumonia after the 5 days. So at that point, the viral replication is low. So I think in that phase, the role of the antiviral drug is minimal at that point. And I think so the most important for the severe COVID patient is the the best supportive care, applying ventilator when needed, and even if the ECMO therapy when needed. And the quality of the supportive care is very important and is the key factor to reduce the mortality, I think.
Yeah. So definitely the degree of supportive care that can be given to the patient is one of the key factors in the survival. One thing that you both mentioned was the fact that several of these patients are asymptomatic, and I think Dr. Che, you presented that a lot of the pediatric patients are very asymptomatic, and I think this poses a very big social dilemma because it is the asymptomatic patients that will spread the virus more easily, and also there is also the issue of how long can we keep our children from going to school. That's all a big social problem as well. So I think that is a big issue, along with the fact that this virus, there's a pretty high viral shedding even in the asymptomatic period. So can you talk about that?
So you give me tough questions to me. So it is very important aspect in the transmission of the virus and also the magnitude of this pandemic. So having a lot of portion of asymptomatic patients, I wouldn't say patient because this doesn't have any symptoms. So asymptomatic cases might contribute to spread the virus very silent way. So they have virus in their upper respiratory tract, and although they have no symptoms like a coughing and spreading droplets from their respiratory tract, but viruses are still there in their respiratory tract. So when they have close contact with household members and close contact in schools, the kids' behaviors are very different from adults. They are not know how they protect themselves from the infected people, and also it is very difficult to educate children, young kids, to prevent how to protect themselves. So having the virus in their respiratory tract is the risk for spreading the virus in the community and also how family and also in school. So that's very important part. And we don't know how long the asymptomatic cases shed the virus. From our study of 91 cases in Korea, the asymptomatic cases spread at average of 14 days. Some spread more than 1 month. It is very close to, similar to other cases who have symptoms. So we don't know the difference of the shedding period of the virus, but we have to know whether children can transmit the virus in the community as same as adults. But one study in Korean experience that we have very strict control and also quarantine and isolation. What we found was that we had 100 children who were able to trace family members who contacted. We followed 250 people. We just have 2 families. The kids spread virus to their family members, which means the second attack rate is only less than 1%, which is very, very low. But we have to be careful about interpreting this data because Korea is very unique country that practice the public health measures employing quarantine and isolation. So if this happens in other countries where the test is not available, the story will be so different. Okay.
Thank you. Another question that we have is the issue of virus reactivation. So there's been a lot of case reports where the patient has was negative, and then they got discharged from the hospital, and then they retested positive a few weeks later. So can you talk about, Dr. Pyung-Kyun Che, can you talk about whether this is reinfection, reactivation, or whether it's just a retest positive?
Yes, from now on, we do not know the exact clinical meaning of the retest positive for the COVID-19 patient. But in my personal opinion, I think is the only genetic material remnant was caused the positive result. Yes, because the PCR, the most weak point of the PCR test is we cannot distinguish from the test result that the genetic material is from the live virus or the dead virus. So, and most of the cases, the CT value of the result is very low. The near the detected limited range, and I think in Korea more than 100 cases were tested repositive, but there were no secondary case from that cases in very intensive contact tracing investigation. So I think the redetection, I think, is the most appropriate term for this phenomenon, and yes, is the redetection of the remnant genetic material.
So at present, we can't say for sure whether it's a reactivation, but more likely is that it's a redetection of the remnant genetic material, is what you're saying. Okay. I think we have covered most of the things, most of the questions that were asked. However, I think because we have this sort of special experience in Korea, where we were able to accommodate a significant portion of the mild patient into the living and treatment support center. And I think that was one of the keys to try to free up a lot of the hospital beds for the more severe patients. And that is what kept the integrity of our health system during the big epidemic in the Daegu, Gyeongbuk province. So can you talk more about what are the indications to what will make the patient a mild case? So what are the indications to send the patient to the living and treatment support center? And if we had a patient in our hospital in the isolation room and the patient was symptomatic, at what time point would you consider sending that patient to the living and treatment support center for monitoring?
Yes, our hospital operated one living and treatment center in Mungyang City, and the indication for the admission for living and treatment center is the 5 criteria. One is patient must be alert, and the age is below 50 years old, and patient only have no underlying disease or one well-controlled underlying disease. And the fourth is the patient body temperature is below 38 degree, whether or not the patient taking antibiotics. And 50 is if patient have no dyspnea. And the indication to transfer the patient from the facility to the hospital is that if the patient complaint about dyspnea, and in our facility we can check the serial chest X-ray for the patient, and if the chest infiltration is progressed, then we will transfer the patient.
Yeah. So the important thing with that model was the fact that it was not a hospital system. We actually put the patient into sort of like a resort type of facility where it was just like a room with a bed. However, we equipped each room with a blood pressure, a digital blood pressure machine, also a digital thermometer, and then a pulse oximetry, which took the saturation. And we were able to, using telemedicine, we were able to monitor these patients, check their vital signs daily, also make sure that there is no spiking fever, and then also that their oxygen saturation was above a certain level. And then we also had a portable X-ray bus outside of that facility so that we could take routine X-ray, chest X-rays whenever needed, so that we can detect the patients who deteriorated clinically, and we're able to send these patients to the local tertiary hospital whenever needed. Yeah, so I think that was very important, and I think for the final question that we need to discuss today is. After this, most countries will have the huge outbreak, and then hopefully it peaks and then starts to come down again. How do you think we need to go back to social normality? I think it would be impossible for us to just one day practice aggressive social distancing, everybody wear masks and nobody touch anything type of situation. To just daily living, it will be almost impossible. So, what do you think will be the keys for us to go back to normality in terms of functioning?
I think we cannot go back to our normal before to coronavirus. But one thing I would suggest is that we have to be very cautious because we might have this virus back in fall or winter season, and we have to be prepared. And we know that all this hand hygiene, wearing mask, and also social distancing is not convenient to us. It is not practical to many of us. So strong and strict social distancing and daily living is not going to be working forever. So sustainability is very important to us. So let's keep at least we can do at daily living. We have to do it persistently from now on. I think it's very important.
So I think one of the keys is that our government has tried to do this in a very methodical, stepwise fashion. So in Korea, currently, the daily confirmed positive new patient numbers are around 10 patients or so per day right now. But the past 4 weeks, our country has practiced very aggressive social distancing. So for the past 4 weeks, a lot of the indoor fitness centers, swimming facilities, people were asked not to, those places closed. People were asked not to have person-to-person meetings. And I think a lot of people adhered to this for the past 4 weeks. And then from the start of this week, we have slightly eased the quarantine measures. So it's a more eased social distancing practice. And I think we will practice this for at least up to the first 10 days of, I think, May, and then maybe the government will make a decision on what to do next. The next phase that I believe the government is planning for is what you just called sort of the daily life social distancing. Which is sort of, we have the aggressive, full-blown social distancing, and then we have sort of the eased social distancing, and then now we're going to maybe, hopefully, in a few weeks, be able to go on to the next level will be sort of daily life, going on with daily life, but actually having a certain degree of social distancing, such as good hand hygiene, wearing masks, but at the same time being able to sort of go back to semi-normal life that we used to enjoy. So I think this sort of stepwise, gradual going back to normal life will be important as well. But as you just said, because there are so many patients who are asymptomatic, we really don't know whether this virus is behind us, even though our numbers of new cases will be at single digits for several days. So I think, as somebody said, we hope for the best, but we have to prepare for the worst. So I think us as healthcare providers, as well as the government, On one hand, we're very hopeful that we can overcome this, but on the other hand, we always have to prepare for next big wave that can come and may come. So I think that will be important as well. So I think with that, it is time for us to wrap up the Q&A session and also today's webinar.